that again, next week, week 8, you have your ATI, and that's MedSurge ATI. So we'll start that at 9 o'clock if that's good for everyone, just a typical time, and we'll log directly into ATI. So it'll be a recorded lecture. Same with the following week. It'll be another recorded lecture because that is week 9, and you have your second exam. I will record a review session. I'll do that today, most likely, and get it uploaded so you have adequate time to view it at your leisure. It'll be the same format as we did last time with it. Just kind of going through that outline, I guess, just a brief kind of review of what we went over in the last couple of weeks. And if that works for you, if you're good with that, I'm good with that. That gives you time to review it and replay it if you need to. So yeah, our campus, the exam is on campus. It's on 11:30 that Tuesday, and it will be at 11 a.m. is what I'm told. And sorry, I'm just shutting some things down. I don't have any control over that at all. This is well above my pay grade, even above some of the local dean level. But I will try to answer any questions that I can. If you sent me an email, I'm just waiting for replies. That's what I'm waiting for. But be there, be prepared, bring your computer, your laptop. They will be providing laptops, but I was told to have you bring yours just in case for some reason. I'll be divided into 2 rooms, and just for COVID precautions for the amount of people that they can have, 20 in a room at max, and they'll be live proctored. So that's that. Any questions that I can answer anyway about the exam coming up? All right, if you have anything, you can always shoot me an email, or you can pop it in the chat or whatever. So the other thing I wanted to go over this week, I'm going to share my screen. There we go. Is our discussion post. So we're going to have a discussion post this week, and many of you have already started that process. Again, let's do that initial post. But just wanted to go over the scenario briefly with you. Again, you're working on a general medical floor, and you're getting a new admit. So here's the data. It's a 58-year-old gentleman. He's got a GI bleed, no surgical history. He's got a history of gastritis and GERD. He takes Prilosec, atenolol, which that can kind of come into play later on. Atenolol, that's a beta blocker. You know, one of the earliest things we look for at shock is tachycardia, and you may not see it when someone's on a beta blocker. And just some other ancillary medications. Again, he went to the physician's office, complaining increased abdominal pain. He's throwing up coffee ground emesis. So we think GI bleed. He states he didn't take his BP medication this morning because he was dizzy. That's probably a good call on his part. And the physician admitting him a diagnosis of GI bleed. He's getting an EGD tomorrow. So he's NPO. He's got a 22 gauge. It's not a very big IV for someone with a GI bleed. And his last set of vital signs, blood pressure 106/60. He's got a heart rate of 98 and respiratory rate of 20, normal thermic. 90% on room air, so a little bit lower. Vomited about 45 minutes ago, that dark coffee ground emesis, and he's got a 4 out of 10 pain. So lab assessment, CBC and a chem panel, and a CT of the abdomen, no sign of free air. So he's not perfed. That's what we're looking for, no perforation. He arrives to you, he's pale, nauseous, skin is cold and clammy. Those are not promising signs. And when he's transferred to the bed or stretcher, he vomits a huge amount of coffee ground emesis and then loses consciousness. That's an even worse sign. So the whole discussion revolves around, you know, while you're receiving the report, what concerns do you have about that client? What type of shock is occurring? You know, and we'll go over the shock stages today and the shock types. And obviously this guy's losing a lot of blood. So what stage of shock is he in? And that's always fun to kind of discuss with each other what you think that stage is and why you think it's that way. And then what's the next interventions and why? And kind of what other labs would you anticipate? And just kind of your thoughts and insights on that patient. Very common patient for you to get in your nursing career are these GI bleeds, the upper and lower GI bleeds. They do have a vast amount of aromas with them that come. I'm sorry, I didn't even have my chat pulled up, so if you typed something in there, there we go. Okay. Yeah, so GI bleeds is a common one you're going to come in contact with, kind of in all aspects of nursing. So again, just be respectful of others when you do your initial post, provide some evidence base to it, one other resource, and reply to 2 other students' posts by the end of the week. Now you have till Sunday midnight at that. But yeah, I like the discussion posts because particularly this group and even my afternoon group, very respectful with each other. As professional, this is all about honing that professional nursing skill too, and how to have a healthy dialogue with colleagues. And you know, whether you agree or disagree, it being able to evidence base that. So there any questions about the discussion this week? All right. If you have any, again, you can put it in the chat or you can send me an email and we'll be good to go. All right. So with that being said, I'll shut off my camera. And this week is all about shock. Shock, shock, shock. So shock's a fun one. There we go. All right. Can everybody see the PowerPoint? Awesome.
Yes, we can do.
Thanks. Appreciate that. All right. So this picture here, I wish I had extra points. Does anyone know who wears pink scrubs? Which trauma center? So there's two of them. This one's in Chicago. So this is University of Chicago has pink scrubs, and so does shock trauma. Actually, this is shock trauma in Baltimore. STC, you can see it on the bottom. So those two wear pink scrubs. But anyway, let's talk about shock itself. We're going to go over a couple of things. So first and foremost, if anyone's looking to get into trauma and emergency medicine, this is a typical scene for a multi-system trauma patient. That's what the room looks like. I can smell that room looking at this picture. It's dirty medicine in the fact that a lot of things happen really quickly. Things get really messy. But there's very quick interventions we can do if we can do them timely for these patients and really, really save them. So we're going to review basic hemodynamics. That's pulmonary artery catheters. We're going to talk about shock, obviously the different types, hypovolemic, much like our discussion post, cardiogenic, obstructive, and distributive. So we look at the hemodynamics themselves. We can. What does it smell like? It smells like a handful of pennies. I know that sounds weird, but the blood itself, the iron in the blood, you can actually smell. So it's a very distinct smell. Yep, that blood smell. You got it, Matt. So let's talk about the basics. I mean, we can spend a whole day talking about hemodynamics, and if you get into critical care medicine, you will get much more training on the hemodynamics. But let's start off with the basics. Just to know that every part of your circulatory system has a pressure to it. There's a quote-unquote blood pressure for every little part, and those pressures are monitored so we can assess the adequacy of like vital organs and tissue perfusion. The pressure measurements are taken from the atria and the ventricles. We can take it from the arterial system, the venous system, pulmonary circulation. We can do intracerebral circulation measurements, portal veins, and monitoring cardiac pressures really helps us assess those conditions such as heart failure. If we see really, really high ventricular pressures or atrial pressures, it's indicative of some sort of failure going on in there. And then we have to kind of dig in just to the basic concept of blood pressure itself, and it has to do with fluid and then the size of the containers, which is our blood vessels. And if you look in that picture on the left here, this just kind of goes over that review of, how does blood get through the body? So if we start off over there in the right ventricle and we go out to that pulmonic valve and it goes to the pulmonary veins and it gets to that capillary permeability interface there, that membrane oxygenation at the alveolar level. So that's where that exchange takes place. It comes back through the pulmonary veins, even though it's oxygenated, and it comes back into the left atria. And it drops down through the bicuspid valve into the left ventricle, where it's ejected through the aortic valve and into systemic circulation. And then it goes up and you have that interchange and that exchange at the capillary cellular level. And then it comes back as it returns from the head and the neck and the upper torso through the superior vena cava. And in the lower extremities, it kind of comes in through the inferior vena cava, right back into the right atria of the heart, deoxygenated. Just a quick refresher of how the blood goes round and round. It's important to understand some hemodynamic values that are associated with it and what they mean. So the SVO2, that's the amount of blood oxygenation level on the venous side when it comes back to the right atria. So it's between 60 and 75%. It doesn't give up all of its oxygen as it's circulating around, so there is a measurable amount. We have stroke volume. That's 50 to 100 mLs. That's how much blood is ejected from that left ventricle in a single squeeze. Generally, we like to say about 70. Stroke index takes that stroke volume and then adds it tailor-made to that patient's size. So it takes mass into effect with that one. Cardiac output, that's how many liters a minute are ejected through the heart, and 4 to 8. That's our general norm. And the cardiac index, again, that's that cardiac output, and just tailoring it to that patient's size with putting in their mass also. One that's going to be important for you guys to kind of remember and play along with is the MAP, the mean arterial pressure. So that's the kind of general pressures that means what it means of arterial pressures. So it's about 60 to 100 or 70 to 110. You will see variance in some of these numbers depending on where you go or what literature you read. However, the map is something that we can calculate, and we will do it today. And it's probably good for you to get that equation down. You're probably going to see it in a little bit. Central venous pressure, we can measure that too. That's just above the right atria. It's usually in the superior vena cava. It's about 2 to 6. And then we have pulmonary artery pressures. And again, much like a blood pressure that we measure that systolically and diastolically. So we have two numbers. You know, it would be 30 over 15 or 20 over 5 or whatever the numbers are. But the systolic is between 20 and 30, and the diastolic is between 5 and 15. Then we have our pulmonary artery obstructive pressure, more commonly as a pulmonary capillary wedge pressure, PCWP. And that's between 8 and 12. And that's when we actually wedge. We'll talk about that a little bit later on. I got a little video to show you on that. And then our final one is our systemic vascular resistance. That's how much resistance that heart has to overcome, the left ventricle, to adequately get that blood to go round and round. All right, this is just a neat picture because the amount of vasculature that we have in our body is amazing. And what's amazing is, you know, when we start manipulating that vasculature by dilating it or constricting it, we can significantly change the pressures within the body and those different blood pressures on there. So when we talk about the cardiac hemodynamics, we want to know what cardiac output is. And that's, again, the amount of blood ejected from the heart each minute. And we need to understand what stroke volume is. And that's the amount of blood ejected from the heart with each beat, like we went over. The heart rate's also important for calculations, and that's number of beats per minute. And our cardiac output, 4 to 8 liters a minute. So the cardiac output we calculate by using the stroke volume and the heart rate. We just multiply those together. So if we got 70 cc's and a heart rate of 70, you multiply those together, and that would be your cardiac output. Again, you can see how that'll change if I have a really, really fast heartbeat or a very, very slow heartbeat, or I don't have enough volume. If my stroke volume is low, that'll change the cardiac output. And there's also a thing called the ejection fraction. Ejection fraction is the percentage of blood that leaves the ventricles at the time it contracts. Does anyone know what the normal EF is on a patient? Because you'd think it's going to be 100%, but it's not. Yeah, 80, a little bit high. Yeah, somewhere between 55 to 70, somewhere around that is a normal ejection fraction. When you start seeing ejection fractions of like 35% or lower, they can be significantly low. That's very severe heart failure for those patients. Okay. All right. A couple of concepts that we're going to refresh your mind. You probably went over these in pathophysiology, maybe some other courses. It's the concept of preload and afterload. And preload is that passive stretching force exerted on the ventricle muscles at the end of diastole, at the end of rest. It's caused by the volume of blood in the ventricles at the end of diastole. And that's the important thing, is we can change preload with volume. If we give too much volume or we take away volume, it'll affect the preload of that patient, which therefore affects cardiac output. An afterload is that whole resistance. That's that force that muscle fiber has to come over in order to circulate blood around. It's considered as the end systolic wall stress in the ventricles. It's the most sensitive measure of afterload is that SVR, the number we went over before, the systemic vascular resistance. And again, it's for the left ventricle and pulmonary vasculatures in the right ventricle. So again, these preload and afterload concepts are something that we as clinicians can manipulate pharmacologically. And we also need to understand them pathophysiologically with the disease states that we come in contact with. So if we know where some of the derangements are, we know how to intervene and make those a little bit better. So we're going to talk a little about contractility. That's that force of the ventricle's contraction. It directly affects the cardiac output, but contractility can be affected by preload and afterload, like we discussed, and anything that affects muscle contraction, electrolyte derangements. Remember, potassium's a huge one, calcium, and sympathetic stimulation. If we give them positive inotropic medications, again, this is us as clinicians intervening. Digoxin, that is a positive inotrope. Dobutamine is a positive inotrope, and we use the words positive or negative on them. So a positive inotrope is going to increase the force of contraction, where a negative inotrope will decrease it. So and also any increase in contractility will cause an increase in myocardial oxygen demand. And that's important for us to know as clinicians and nurses, is that if we have a patient, let's say in congestive heart failure going into cardiogenic shock, and we put them on dobutamine, we're going to increase the amount of muscle contraction, which is going to increase the amount of oxygen that that heart needs. And that heart is already stressed. So sometimes our therapies, if we go a little too aggressive, can cause problems versus correcting problems. Some of the other terms that we need to know. So inotropic, that has to do with contractility. Chronotropic, and you think chronos is time, that has to do with heart rate. So the chronotropic. And we can give medications for all of these. And dromotropic is the effect of the speed of the AV node. So the inotropic drugs, digoxin, dobutamine, a chronotropic drug. A positive chronotrope would be something like epinephrine. It's going to speed up the heart rate. Then we have negative chronotropic. Anyone have a guess what a negative chronotropic drug would be? Yeah, adenosine. Yeah, that's going to be an abruptly negative chronotropic. But more common ones that we see are the LALs of the world, like beta blockers. Yeah, absolutely. They're meant to slow the heart rate down. And what about dromotropes? Do we have any negative dromotropes that we can give to slow down, say, electrical activity in the heart? Kind of alluded to it earlier with some of the electrolytes, but we can give calcium channel blockers, and that'll help slow stuff down. So, yeah, there you go, Rochelle. Good job. So you see how it kind of all starts to interact with each other when we start talking about hemodynamics and how we can really improve or deteriorate a patient with our interventions with that. So let's talk about that central venous pressure. This is the pressure measured in the central veins close to the heart. It indicates mean right atrial pressure, and it's frequently used an estimate of right ventricular preload. This is where we get our preload looking for, and we can use this to assess volume status of our patient. So the catheter is inserted, it sits superior vena cava, like we said. Normal CVP is about 2 to 6, 2 to 8, you may see 2 to 10, but in that general ballpark. So if we have a decrease in that, if it's, say, 1, then we're going to think, hypovolemia, and maybe shock. An increase in that, we're going to think fluid overload. Maybe they're in congestive heart failure. Maybe it's cardiac tamponade, so maybe it's just profound vasoconstriction. But again, having those numbers and understanding what they mean can give us a little bit of a clue, a little insight into what that patient's going through. So if the CVP is increased, treatments may include diureses. We may give them vasodilators to decrease afterload. And also, if the underlying condition is there, we can treat that. So looking at the arterial circulation, we have to talk a little bit about arterial blood pressures. So we have non-invasive, that's a sphygmomanometer. I always remember that word because I had my buddy Sphig, his mom, and a meter. That's how I remember how to say that. And invasive, which is arterial lines or art lines or an A line, which gives you really beat to beat. Blood pressure is influenced by cardiac output, total peripheral resistance, and arterial stiffness too. So these patients who have this atherosclerotic disease and underlying hypertension can really affect their arterial blood pressure. Digging into that arterial lines and those A lines, but again, art line or an A line is what it's usually described as. And the indications for that can be just hemodynamic instability, someone who requires constant continuous monitoring of blood pressure to facilitate reliable titration of supportive medications. Vasoactive medications are someone we'd like to have an art line in. Dopamine, norepi, nitroprusside, those are all medications that, again, this gives us a beat-to-beat identification of their blood pressure. It's not a range. It's not a snapshot in time like a non-invasive blood pressure when you use a blood pressure cuff. This is telling you real time what's going on, and you can actually see someone quickly deteriorate. Let's say if they're hypovolemic or they're given too much of a vasodilator, you can see that waveform degrade. So shocky patients, serious MIs, cardiac surgery, a lot of surgeries they'll put in art lines just when they're given a different type of sedation and medications. Mechanically ventilated patients, it's good because they can get frequent blood gases out of them. Sometimes even when there's procedures done that they're going to be in for a while and they're going to be checking that arterial blood gases, it's easy because they can just shut that off, open it, pull blood. Patient doesn't need another needle stick. Use what you need, and they usually give back. So, if I'm withdrawing 5 milliliters of fluid, of blood from that patient, and I only require, 4 drops, I put the blood back again, because we can make somebody hypovolemic as clinicians by taking too much blood. There's been lots of policies and procedures written around that concept because it's been identified. And again, it continuously displays the blood pressure, and you can get the ABGs, and again, we get to monitor their cardiac output. So when we talk about the catheters in general that we use, the radial artery is usually the most common site. You can see that up in the upper right picture there. It's very common what it looks like. Sometimes they have a little splint that they put on to prevent the patient from kind of plantar flexing or dorsiflexing their hands and moving them, flopping up and down. It's inserted into the radial artery, but they have to do an Allen's test and to look for good collateral circulation. I got a quick video. It's literally a minute long, but it shows you an Allen test and how to do an Allen test, but more importantly, what you're looking for in that Allen test here. So, there we go. I'm going to unplug so you can hear this and turn it up.
The test, ask your patient to open and close the hand several times as quickly as possible and then squeeze the hand tightly. Then compress the radial and the ulnar arteries with your thumbs. Hold it quickly and then ask your patient to open the hand and release the radial artery. And you can see how the blood is streaming back into the hand quickly. We will now repeat the same process and release the ulnar artery.
All right, so you get the idea of how that works. So let me open this back up. It's funny, the Allen test, what's more important, do you think, when you're putting in a radial art line? Do you think it's more important to have the radial blood flow or more important to have ulnar collateral blood flow? Yeah, ulnar, absolutely. Yeah, because you're going to have that catheter and it's going to be occupying that radial artery. You want to make sure that it's perfusing because that picture below is an actual necrotic hand from just having a complete lack of perfusion. So a fun fact is I fail an Allen's test on my right hand. I went through a window many, many, many years ago and lacerated my ulnar artery, and they just ligated it. So I failed the Allen's test. So no art line in Erik for the right arm. All right, let's talk back this here. Complications, like we said, pain, infection, hemorrhage. And this is a silly one. I'll tell a tale out of school on myself. Is I was taking care of a patient in an MRI, and got him all set in there. I was transferring him in there. It was a bleed or something, and this is way back then. But I look over and it's just wet blood, and the art line actually got kinked open, the little stopcock open, and patient was exsanguinating out of that. And they can hemorrhage quickly out of that. It is arterial blood flow, that is for sure. Arterial insufficiency, occlusion, thrombus, embolism, nerve damage. So it's something we all have to be careful of when we deal with patients with art lines in. So here's when we're talking about the mean arterial pressure. So what does that mean? It's the average pressure in a patient's arteries during one cardiac cycle. It's considered a better indicator of perfusion to vital organs than just the systolic blood pressure. So it kind of gives us a general picture of that. And we can calculate that. So it's the cardiac output times systemic vascular resistance plus, excuse me, sorry, cerebral vascular perfusion, excuse me. Okay, so the way we can calculate it are two ways. One is the most common. You take the systolic blood pressure and you plus 2 times the diastolic blood pressure and you divide that by 3. Or you can take 1/3 the systolic blood pressure minus the diastolic blood pressure and add the diastolic blood pressure. The upper one is far easier to do mathematically. And the normal is between 70 and 110, as we saw earlier. And that's what that reflects what the literature in the book says here. So BP up, MAP goes up. BP goes down, the MAP goes down. So it's an important concept. So again, 2 times the diastolic plus the systolic, and you just divide that by 3. So if you have 120 over 80, again, 2 times 80, 160, plus 120, and you divide that by 3, it gives you 93. There's a couple of examples that are here on this. I would encourage you just to kind of run through these and even make your own up to find out. It might come back. You might see this later on. And it's important for you as clinicians, too, to understand the concept of a map, how to calculate a map, and understand when it's starting to go out of either be way too low or way too high, and how we can kind of intervene with that. All right. Other thing to talk about too are these different catheter types. So we have peripheral venous access. Those are short peripheral catheters. You can see that in the center there. We have midline catheters, and their distal end goes to the axillary vein, so they're a little bit longer. Then we have our central venous catheters. They're peripherally inserted central line, a PICC line. Again, it goes that the superior vena cava, the distal third, that's where that tip's going to lie. It's tunneled catheters. Those are inserted like internal jugulars, and then to get it out of the patient's face, they kind of tunnel them under the skin and have them come out of the chest, even though it's going into an internal jugular. Non-tunneled catheters, that's just a standard subclavian line or an internal jugular or femoral line that's not tunneled through the skin. It's where it comes out is where it comes out. Implanted ports, those are tunneled in. They're usually done under conscious sedation. We also have pulmonary artery catheters and arterial lines and umbilical lines if you want to work with the little babies. And then intraosseous lines that have become much more popular over the last several years in the fact that we can cannulate that medullary network. It's a non-collapsible venous network that's available in every single patient, so we can tap into that. And here's some pictures you can see of them. General catheters on the left-hand side. You can see the art line there in the lower one. An IO catheter is kind of in the center, that yellow up around here. And then the different types. So a PICC line, you can see it's where the distal end is. That's up here in a distal third of the superior vena cava, where midlines, it ends up at the axillary. And then this is the different types of central lines that you can have. The implanted ports here, non-tunneled, tunneled catheters here, so it's coming back out more comfortable. And this, of course, is an umbilical line. You can put those in for those little tiny newborns that need some vascular access. All right. Any questions? Going too fast? Good amount? Okay, good. All right. So pulmonary artery catheters, looking at this, there's called a Swan-Ganz catheter, if you've ever seen that. And that's with a little picture of the swans up there. So these Swan catheters measure pulmonary artery pressures continuously. And then they can do a pulmonary capillary wedge pressure. And what it is it's inserted venously, and it's usually snaked up from a femoral vein, and it go up into the right atria. And it uses a little balloon to guide its way through the entire heart. And as it goes through, we can see all these different waveforms and take all of those measurements. And we can take samples of different blood samples in those, the right ventricle, the pulmonary artery, the right atria, all that, and see how the patient's doing physiologically. I have this little video here too, which just shows you how the Swan-Ganz works. And again, there's no audio to this, but you can see they just get the catheter in, they'll inflate the balloon, and that helps it just guide itself through the heart. So as it starts to advance, there's your CVP, central venous pressure. You get into the right atrium. Oh, once it goes through, you're in the right ventricle. That's where you're going to see a very high spike, and you'll see larger numbers. And as it goes through the pulmonary arterial system, they're going to get a wedge pressure. That wedge pressure is indirectly telling us how the left atria and left ventricles work. Again, we can't measure that through the venous side, so we use this little balloon-tipped catheter that has a forward-looking sensor, and now it's measuring the pressures distally. So that wedge pressure is giving us a little insight into how the left side of the heart is working, even though we can't access it through the venous side. It is crazy, man. Yeah, it's impressive. We do these right-sided heart catheterizations in cath labs. They don't just do the left side where they look at the coronary vasculature. A right heart cath looks at all of those pressures. It's really good for congestive heart failure patients and how to really tailor them. Yeah, and it does look like a swan. Absolutely. All right, so the catheter itself, it may be used to monitor patients in shock. It is invasive, so it's interned to the pulmonary capillary bed via the internal femoral, jugular, or subclavian. And again, pulmonary venous pressures, right and left-sided heart pressures, and cardiac output. We can get core temperatures too. That's an important thing. Oxygen saturation, systemic pulmonary vascular resistance, and it's attached to a pressurized IV, which keeps the blood from exiting. It's a very slow drip. It goes 3 cc's an hour, to be exact. The mechanical energy transmitted through the catheter from the heart is converted to electrical energy, and it's showed on the cardiac monitor. So it's pretty cool. The Swans they wax and wane in use and availability. But it prevents us. Before this, we used to have to do what's called shooting a cardiac output for patients. So you give, 3 10 milliliter fluid injections over a time frame, and it would calculate your cardiac output. Now it's still done, but it's not done at the bedside so much, because what happens? What happens if we have a cardiac CHF patient and we're measuring cardiac outputs every hour? That's 30 milliliters of fluid every hour that goes in. We can also change, temperature wise with that. So they can get hypothermic with it. So we really try to avoid that. We can do that by doing this, although it's invasive. It doesn't require the addition of more fluid, and we can really get a good look at that patient's hemodynamics. So the waveforms that you see over here on the left-hand side, the right atria, which is your CVP, obviously has the lowest amount of pressure. It's in the venous system. But once it goes down into that right ventricle, again, you think that ventricle's bigger. It squeezes, so it generates more pressures. So that's where you're going to see a larger waveform. And in the pulmonary artery, we talked about that pulmonary artery pressure. You're measuring the systolic and diastolic, and you can see the waveform reflects that, what the norms we're going to see. And then as you get into that pulmonary capillary wedge, that's what's giving us that indirect look at the other side of the heart. So again, that video shows a good depiction of how it floats through the system, and we can really get those real-time measurements. So when we talk again about that wedge pressure, it's the pulmonary wedge pressures. Pulmonary artery pressure indirectly measures the left atria and the left ventricle. Again, it's a catheter is inserted, as you saw, and it's threaded through the vena cava, and it gets into the pulmonary artery, and then we wedge it. We inflate that balloon, and the catheter wedges in the pulmonary artery. And that tip of the balloon, again, looks at the arterial system on the left side. But before inflation, we can read the pulmonary artery pressures. So we get that pulmonary artery pressure, and then when we inflate it, we get that indirect look at the left atria and that left side of the system. We have to be careful with this. We use it mainly to assess heart failure in patients. But what can be a problem if we inflate that balloon and leave it there?
I was just going to say that, like, once you get there, you're just basically occluding the entire blood flow, right? So you just got to, like, get there and deflate the balloon, like, as soon as you know you're in place. Like, that seems kind of...
Yeah, you're
like,
100% correct.
That seems kind of scary, Like, I don't know.
You're giving somebody a pulmonary embolism for a brief amount of time. But yeah, so that's why we try to get it in. The balloon goes, it's very, very small. But what's very, very important for nurses is that, we as nurses do not do wedge pressures. We're not inflating that balloon. We can deflate the balloon, but most of the time we're not getting that wedge pressure for exactly what you said, Matt, is you're creating a pulmonary embolism. So that can be a problem if there's a thing called a permanent wedge. Let's say you inflate that balloon and you can't deflate it. Now is where we run into that problem. Like, oh no, now there's going to be serious consequences from these patients. So it's very important. There's a very special syringe. It does not allow more than, I think it's 1.2 milliliters of air in it. It's locked. That balloon, where you access it to inflate it, locks open or closed, so you can't access it. But one of the things you do as a clinician, if you're working in the critical care arena and someone with a Swan-Ganz catheter in, is to first thing make sure that the balloon's deflated, because that can migrate around and cause serious problems, just as what we said. So it heightens our clinical assessment skills, because now we have an added potential problem. But yeah, you hit the nail right on the head. It blocks that blood flow. All right. So yeah.
One more thing about the Swan, because I don't know. I've never seen one. Like, I've seen one in like a package, and like they were gonna do one. They wanted to do one in the ER once, and like nobody knew what the heck to do. So they called a bunch of CTICU nurses down, and they ended up not doing it. But I was just looking at it, and I was stressed out just looking at the package, and like, so is that thing left in place? Like, once I know, obviously the doctors are putting it in. It's like, is it like left there so they can, like, how long is that going to stay in somebody?
Yeah. So they'll pull it back. It's a central line too. You can still administer drugs and fluids and get blood out of that too. So it's a triple lumen, and in addition, it has the sensor on the end. So it is left in place, but it's not left in the pulmonary artery. They'll usually pull it back.
All right, they pull it back, and it's like a subclavian central line at that point.
It's exactly what it is, and it has this in the packaging. If you looked at it, it has this kind of clear covering over it, and we affectionately call it the swandom, because it's like a condom for the Swan catheter. And that when it's pulled out, it still keeps it in a sterile environment. So when they remove it, and then you document too, where is it? So you need to know the length that it's in and the length it is when it gets wedged, because those need to be documented, and you're always looking to make sure that it's not wedged or migrating around. So we as nurses won't manipulate that at all. But yeah, it's funny in the ER, because that's been my whole background. You throw a Swan at them, and whoa, because you have to know exactly what you're looking at.
It was some kind of trauma, and then they weren't sure if it was like it ended up being a tamponade, but they weren't sure if this was this or that or the other, and they were going to do one of these, and nobody knew what the heck to do, and it was bedlam for a minute.
Yeah, yep, exactly. But no, good conversation. I appreciate that. Thank you. All right, this here's a link to go over some pharmacology with hemodynamics. It opened up yesterday fine. I clicked it today, and it didn't open up. So I don't know if it's a problem with the site itself, but when you open that up, it allows you to go over all the different pharmacology with hemodynamics, and it breaks it down to cardiac and blood thinners, everything. It's a really great resource for you. But let's talk a little bit about some of these medications and what they're used for. So dobutamine, well, we heard that earlier today. Dobutamine is a positive inotrope, and that increases contractility of the heart. So patients in heart failure usually get dobutamine unless they're hypotensive. Then we don't give it. Then we have to play around with blood pressure first. And that's where our old friend dopamine comes in. Now, you probably remember dopamine from the Parkinson's lectures, because there's a lack of dopamine, and the substantia nigra causes that in the central circulation. But when we give dopamine peripherally, it directly affects the vasculature in the heart. So, and it comes in a range, and it used to have a renal dose of dopamine, like 2 to 5, where it constricts down the blood vessels, but it dilates out the renal arteries. Then that mid-range gives you a little bit of a heart rate increase and a little bit of vasoconstriction throughout the body, and that's about 2 to 10. And then there's the 10 to 20 is the pure alpha. If you're given high doses of dopamine, it causes pure alpha stimulation, and that's vasoconstriction. So we can play around with dopamine and get different results with different dosage. And both of those medications take the patient's weight into consideration. Those are given in mics per kilogram per minute. We can give epinephrine. If we all remember epinephrine, we secrete that, and that is a sympathetic drug, sympathomimetic, actually. So you give epinephrine, you're going to see everything in that fight or flight, all the stress response, increased heart rate, increased blood pressure, bronchodilation. But epinephrine we use for patients with profound hypotension that might not respond to something like dopamine. So patients in maybe neurogenic shock, they need alpha stimulation because the dopaminergic aspect is not going to constrict those blood vessels. Morphine, what's morphine do if we give it, aside from make them happy? Does that increase the blood pressure or decrease it? Yeah, low, Rochelle, absolutely. That's why when we give morphine, when we give it IV push, we give it a little bit slow for two reasons. One, it can drop their blood pressure really quick. Two, they get really, really nauseated from it and can vomit. But yeah, be careful when you're administering morphine. Nitroglycerin, that's a vasodilator, and we can give nitroglycerin in several different forms. We can give it sublingually to patients. We can give it intravenously as a continuous drip, or we can give it as a paste, nitro paste. Has anyone heard of nitro paste before? I brought it up in a simulation last week, yeah, and just to understand that it's given, and that's given in measured out in half inch, 2 inches. So there's a little piece of paper that you put it on that's got measurements on it, and you just tape it to the patient's chest. But no, as a nurse, if you're giving someone nitroglycerin in nitro paste form, be careful, because if you get it on yourself, your blood pressure is going to go down a little bit, and more likely you're just going to have a headache. Excellent. There you go, Cynthia. Gives you a bad headache. Absolutely. It's a vasodilator. Wear your gloves. Nitroprusside, that is a very potent vasodilator, and that is a drug when it's given continuously IV. It has to be protected from light because it degrades the efficacy of it. So it's usually a brown bag that's placed over it. So when you give that, and that needs this medication, they definitely need to have an arterial line in because you need minuscule changes to that can really, really have significant effects. on the blood pressure. And then our last one is norepinephrine or Levophed. And does anyone remember the old saying for Levophed? So Levophed is a very potent vasoconstrictor. And the old saying that we used to say, if you're given Levophed, it's Levophed will leave them dead, because it's just going to shut down every one of their organs and they're going to die of, systemic failure, which is untrue. As a matter of fact, norepinephrine has come back with a vengeance and is really the drug of choice in a lot of what we do for hypotensive patients. We just know how we can regulate it a little better now and know that it doesn't have those deleterious effects that it used to have. The studies show that it's actually improved outcomes. And that picture on the right-hand side is no joke. If any of you have been to an intensive care unit, or a trauma unit, or someone who's really, really sick, that is what it looks like. And those pumps that we have on campus, they're the Alaris pumps. They will make your life much, much better if you learn how to use those. But, and knowing if you have them on a bunch of these medications, Advent uses the plum system, which is different. But they all have things called guardrail drugs, or kind of parameters that help you not make mistakes. But know your drug compatibilities. So, what time is it now? 9:41. Everyone still good? Keep going? Yep. Okay. All right, let's talk about the shock syndromes. So here's a nice picture. Again, the PowerPoint's up in Blackboard. You can download this, and it's a good synopsis of it. It's a good table. So we'll talk a little bit about hypovolemic. That's probably one of the more common ones that we can come in contact with. It could be poor clotting, dehydration, hemorrhage, nausea, vomiting, burns, any way that you lose volume. It's a volume loss and plasma loss. So that's the underlying etiology of hypovolemic shock. Now, cardiogenic, again, it's in the word cardio, so it's heart. A lot of times, the etiology can be a myocardial infarction. That's by far the most common form, but you can have dysrhythmias. If your heart rate is 220, it doesn't have enough time to fill, so it doesn't have any blood to squirt out, so you become shocky and hypotensive for that. The opposite extreme, if I have a heart rate of 30, it's not pumping fast enough to adequately meet the needs of my body, so therefore I can be shocky from that. Blunt cardiac trauma, absolutely, that can cause cardiac tamponades, which is an obstructive, but the blunt trauma itself can cause loss of contractility and dysrhythmias, and lethal ones, I think, called commotio cordis, where that's what a lot of baseball players, they get hit in the chest. You hear about those kids, and then they immediately go into cardiac arrest. That's from blunt trauma that's preceded like a brief cardiogenic shock. Then we have our obstructive shocks. The etiologies of that could be a cardiac tamponade. Again, that cardiac sac is filling with fluid and squeezing the heart. Tension pneumothorax, we discussed that a few weeks ago. Again, air is entering, it's squeezing and compressing and shifting the mediastinum, and it squeezes that heart. So again, both of those, they can't fill with blood and they can't eject fluid off. And then a tension in hemothorax, it can be fluid filled and blood filled that can actually do that. And then we have our distributive shocks, which are neurogenic. Again, you lose that vasomotor tone from the level of the injury down. And those are the ones that have low blood pressure and bradycardia, not tachycardia with it. So anaphylactic shock, it's profound vasodilatation of blood vessels. Again, that's an IgE immune response. And septic shock, that's mediated by systemic inflammatory response syndrome, hypotension, and perfusion abnormalities. You get all these endotoxins and other mediators, and they cause massive vasodilation. So it's a horrible distributive shock. So let's talk about hypovolemic shock, because that's a pretty common one. The definition is just loss of vascular volume, resulting in a decreased MAP. Again, remember, it's either volume or tank size. It results in inadequate total body perfusion and gas exchange. So you get a decrease in the MAP, about 5 to 10 millimeters of mercury below the patient's normal baseline, and detected by baroreceptors in the aortic arch and the carotid sinus. So info sent to the brain, and then all of a sudden our compensatory mechanisms kick in. The renin-angiotensin-aldosterone system that adds volume, and it causes vasoconstriction. So blood is shunted away from these periphery to vital organs. And vital organs, I mean heart, brain, and kidney. And actually, sadly, your body doesn't consider the kidney as important, so it'll shut that down. But that renin-angiotensin-aldosterone system, remember, renin stimulates the secretion of angiotensinogen, which goes through the body and produces angiotensin 1. Angiotensin 1 goes to the lungs and is cleaved to angiotensin 2 by the angiotensin converting enzyme. Angiotensin 2, very potent vasoconstrictor. And then renin also stimulates the release of aldosterone, and aldosterone, when it's secreted, causes the reabsorption of sodium and water from the distal renal tubules, so that adds volume. Remember, whenever you hold on to sodium, water follows sodium. So the renin angiotensin aldosterone system, it's a twofer, actually a threefer, because then it stimulates antidiuretic hormone to be produced. The causes of hypovolemic shock can be loss of circulating volume, so blood loss, GI ulcer surgeries, inadequate clotting, dehydration, vomiting, diarrhea, very common in pediatric patients that are really sick for a while. They can be profoundly hypovolemic just from vomiting and diarrhea. Heavy diaphoresis, diuretic therapy, anything where you're losing fluid can set you up for possibility of hypovolemic shock. So when you look at the pathophysiology of it, so that hypovolemia causes a decrease in venous return, right? So that's preload. Decreased preload. And remember, cardiac output is systemic, is stroke volume times heart rate. So we start to get a decrease in cardiac output. So, and our blood pressure is affected because it's cardiac output and total peripheral resistance. So they get hypotensive. And that causes perfusion failure and tissue hypoxia, which can lead to organ dysfunction and multi-organ failure. That's the next week lecture. We'll talk about MODS and multi-organ failure. But it's a slippery slope. If you don't start intervening, it starts to go downhill quick. And when your body starts to clamp down, it's going to clamp down around those kidneys, and then renal failure, and then liver failure, and then multi-organ failure. And it becomes quite devastating. So the stages are something to discuss about shock. So we have that initial stage. That's where that baseline map decreases about 5 to 10. You get the sympathetic stimulation. That's where your body's, kind of kicking in. You get a little mild vasoconstriction, increased heart rate, increased respiratory rate, everything you would see from a sympathetic nervous system response. Then there's a non-progressive or compensatory stage. That's where the map decreased about 10 to 15 from baseline. So you get the continued sympathetic stimulation, moderate vasoconstriction with decreased peripheral pulses. Again, weak pulses, increased heart rate, decreased pulse pressure. The renin, angiotensin, aldosterone system are secreted, so you get a decreased urine output. They get thirsty and mildly acidotic at this point, and they may be slightly hyperkalemic. So again, everything you would see for someone that's really starting to lose just a little bit more volume. Then it gets to that progressive stage. That's where that map is more than 20 millimeter mercury away, anoxia of non-vital organs, hypoxia of vital organs. So what happens when we have hypoxia of a vital organ? So when somebody gets symptomatic, what do we consider vital organs? Brain, absolutely. The heart. So what symptoms would you see that would say, okay, this person is in a progressive stage of shock? Altered mentation, that's hypoxia, unconsciousness, chest pain. So those are things that would elude me that this is a very serious progressive stage of shock when they're starting to clinically manifest hypoxic signs of vital organs like the heart and brain, and then the kidneys are going to be shutting down too. Or anaerobic metabolism, moderate acidosis, hyperkalemic, and tissue ischemia. And that's where you see chest discomfort and maybe even unconsciousness. Then finally, that refractory phase stage, rather. It's a severe tissue hypoxia with ischemia, necrosis. You release all these myocardial depressant factors from the pancreas, toxic metabolites build up, and this is where they get into MODS, multi-organ dysfunction syndrome, and that'll ultimately proceed to death. It can proceed pretty quickly. So it's just kind of getting to know the different stages of shock here, and that's what that discussion was about, to kind of help you assess that. Myocardial depressant factor, so it does is it decreases the myocardial contractility, and it constricts the splanchnic, which is abdominal arteries, and impairs phagocytosis. So it causes a lot of issues. So, all right. So what do we see with these patients when we assess them? Confusion, pale. They're pale because of vasoconstriction, moist, decreased capillary refill. That's a very important clinical assessment that we should do. It takes nothing to do with capillary refill. Should be about 2 seconds or less. When it starts to get to 3, 4, 5, then we have some issues. Declining mean arterial pressure, increased heart rate and respiratory rate, and decreased output. We decreases central venous pressures. In the compensatory stages, the BP is still elevated due to that sympathetic response. Remember, it's compensating. Weak and thready pulses. What does that mean? That means they're heart rate has gone up, but they've clamped down that peripheral vasculature, so it's hard to feel those peripheral pulses. They're really weak and thready. Lab work that we see is CBC, so we want to look at the H&H. What's the hematocrit hemoglobin? What's the oxygen carrying capacity, and what is the hematocrit level? Have they lost a significant amount of blood? We look at the chemistry, specifically potassium and lactic acid. Lactic acid is huge for us, and we type and screen them. Type and screen, not scream. And we can get ABGs. Lactate and potassium levels are elevated. So we can actually track how our interventions are working by monitoring lactate levels and potassium levels. So interventions, of course, fix the underlying problem. If they're bleeding from an artery, put a tourniquet on it. Okay, then we can start to fix them. They all get the OMI, oxygen, cardiac monitor, and IVs. So O2s, they prefer 2 large bore IVs. Usually use the antecubital veins because it's a larger vein. You can put a larger catheter in there. Cardiac monitor. And fluids, they can get ringers. That's a common one. Plasma expanders and packed cells. So there's a lot of debate going on now about the use of colloids and the use of isotonic fluids like ringers and saline in hypovolemic patients from blood loss, and the fact that it really is lending to a lot of more acidosis. So the trend is early aggressive blood therapy rather than fluid therapy. We're over-salinizing these patients, and they have significantly poorer outcomes. So packed red blood cells only use 9% saline. Does anyone know why? Yep. So 9% saline for several reasons. One, it causes no physiologic cellular shifts with fluid. You put it in the vascular system, it's an isotonic fluid, fine. It's compatible with blood, exactly. And the fact that some of the other things, like lactated ringers, for example, can cause blood to clot. So we don't use that. We use saline. We prime it and then give the blood and then use saline throughout it. So again, you're only using saline because that's what's not shifting any fluids into the cell, in or out of the cells, and it's compatible with the packed cells. Patient, put them supine and put their feet up. That's something a very easy nursing can do. Why do we elevate their feet? Any guesses on that?
Just gravity sends more blood to the vital organs.
You got it. Boom. Just like that. A very simple maneuver. Yep. Put them flat, put their feet up. And then we just monitor them. That's what nurses are really good at, monitoring the vital signs. You're looking for trends in all this. Are they improving? Is the blood pressure coming up? Is the heart rate going down? Or opposite, is the blood pressure going down? Is the MAP going down? Is the heart rate continuing to climb? Are my saturations maintaining? ABG, skin, color, are they still pale? Are they getting pink? And the cognition, are they starting to mentate better? So, and of course, we can use those central lines and arterial lines to help us, A, pharmacologically intervene, and B, monitor those pressures real time, beat by beat. Any questions about hypovolemic shock? What time is it here? Do you guys need a break? Or power through? All right, we'll keep going then. Nope, perfect. All right, so let's talk about cardiogenic shock. And again, we've alluded to that earlier. It's to do with the heart. So the definition is occurs when the heart muscle is impaired. It's pump failure. Myocardial infarction is by far the most common direct pump failure cause. Other causes, though, you can have a cardiac arrest. That's not going to do anything. You come back and you have some cardiomyopathies with that. Ventricular dysrhythmias, we spoke about that, too fast or too slow. Cardiac amyloidosis, again, those amyloid deposits from Alzheimer's disease in the brain, they can actually impair the muscle fibers too and impair the contractility. Cardiomyopathies, that's where the heart gets kind of floppy. And you can have dilated cardiomyopathy or constricted cardiomyopathy, but the underlying cause, the effect is that the heart doesn't pump effectively. And just myocardial degeneration. So how do we intervene with these patients? Again, OMI, they give them oxygen, put them on a monitor, get some IVs, and try to determine that underlying cause and treat it. So, ACLS may come into play here. Treatments for STEMIs, they might have to go to the cath lab and, get balloon, stented, clot removed. And sometimes when they're in there and they're in profound cardiogenic shock, we can help them along in those interventional suites by putting in an intra-aortic balloon pump or an Impella device. I'll talk about that in a second. But usually they're going to require central line, arterial lines, possibly the pulmonary artery catheters. We really need to monitor the pressures in these patients. Dobutamine is a great drug for cardiogenic shock. However, they have to have a blood pressure above 100 systolically. We're going to monitor these labs for these patients too. CBC, CMP, cardiac enzymes, troponin, and B-type natriuretic peptide, BNP. That's a good one we can measure for these patients too. It's kind of when the heart is stressed and it squeezes, it kind of secretes out. Think of a sponge squeezing out when you squeeze it, and that liquid comes out, and that could be a BNP. So when the heart is stressed, that type B natriuretic peptide is actually measurable in a patient. It gets elevated. So post-MI classifications of post-myocardial infarction heart failure. There's class 1 that responds well to reduction of preload with nitrates and diuretics. Class 2 and 3, a little bit worse, requires more aggressive interventions, meds like nitroprusside, nitroglycerin, decrease both preload and afterload, and we want to monitor the vital signs and specifically the blood pressure. Class 4 is cardiogenic shock. Necrosis of 40% of the left ventricle occurs. Signs and symptoms, they're tachycardic, they're hypotensive. Blood pressure is less than 90 or 30 millimeters of mercury less than their baseline. Cold, clammy, really poor peripheral pulses. They're agitated, restless, and confused. Pulmonary congested, pulmonary edema, tachypnea, chest discomfort, decreased urine output. If you see someone in cardiogenic shock, you will not forget it. They are very, very sick patients. Some of the sickest patients I've ever taken care of have been in profound cardiogenic shock. And these patients may require to be intubated because we have to control their airway. We have to control pressures in there. Medications to relieve pain. Morphine is also a vasodilator. Decrease the oxygen consumption requirements, and preload and afterload reduction. So I touched about earlier about an intra-aortic balloon pump. Has anybody seen an intra-aortic balloon pump or had any dealings with it? So the whole premise of an intra-aortic balloon pump is they take this device. It's a balloon. It's a long, thin balloon, and it's inserted through the femoral artery, and it goes up, and it's inserted where it's lying just above the renal arteries and below the aortic arch. So this long balloon is connected to a machine which is connected to the patient for their hemodynamics. It's seeing all of their arterial pressures, EKGs, and what it does is it times the inflation and deflation of that balloon in concert with the patient's heart contracting and relaxing, that diastole and systole. So the theory behind it, which is sound and it works, is as the heart contracts, that balloon immediately deflates. And when it deflates, it creates a vacuum and it pulls blood out of the left ventricle. And as the heart relaxes in diastole, it inflates rapidly. And what that does is it forces blood through the coronary artery system to hyperperfuse and hyperoxygenate the myocardium. And it goes in time with every beat. And even if the patient has an irregular heartbeat, it times that. It uses pressure and ECG signals to time it. And you can actually manipulate some of those timings, but you can take a patient in cardiogenic shock and make them significantly better with an intra-aortic balloon pump. The other device that I talked about was an Impella. And if you know what an Impella is, jet skis work on an Impella. So you press the gas on a jet ski, it sucks water in and it blows it out the back end, and it just displaces fluid. So we can take this Impella device and put it through the femoral artery, and again, we can put it up and place it through the aortic valve. So the distal ends in the left ventricle and the proximal ends in the aorta. And what it does is it actually uses that Impella and it sucks that blood out of the ventricle. So the whole goal of both of those therapies, intra-aortic balloon pump and an Impella, is to reduce the strain on the heart. Take a little bit of that load off them. You don't need to move the blood around. Let us help you move that blood around. Any questions on those? Again, you can take a day class on each of those therapies. Does that make sense, or did I confuse everybody? If you want more clarification, I can send stuff out if anyone's interested. All right, so again, about a third of the patients with inferior wall MIs will develop right ventricular heart failure. Signs and symptoms of that: decreased cardiac output, paradoxical pulses. They have clear lungs. Remember, right-sided failure, they get edema. So jugular venous distension in semi-Fowler's position. They get a high CVP with hypotension and bradyarrhythmias. So the goal is to improve that right ventricular stroke volume by increasing the ventricular fiber stretch or preload. So we give fluids to increase right atrial pressures, monitor with pulmonary artery wedge pressure. So those inferior wall MIs, we initially give them a little bit of a fluid bolus. We give them positive inotropes to increase the contractility, and we stay away from nitrates. We don't want to kind of dilate them out any more than they are. Okay. Again, this is a good picture for you to right-click and save to kind of look at what part and what drugs and what do they treat, and what disease states are they mostly used in, and what do they do to the body? What are afterload reducers, which ones treat angina, and preload reducers. So it's a great little thing to have, and that was courtesy of cardionursing.com. All right, let's talk about obstructive shock then. Definition of obstructive shock is the cardiac function is impaired due to a physical obstruction of circulation either into or out of the heart. So the causes of that, think about that, the tamponades, constrictive pericarditis, tension pneumothorax, anything that's going to squeeze that heart closed. So the assessment intervention kind of depends on what that underlying cause is. So if it's cardiac tamponade, we're going to hear muffled heart sounds. We're going to see jugular venous distension and hypotension. We get a narrowed pulse pressure, and pulsus paradoxus. And that's where you get one very palpable beat, one weak beat, one palpable, one weak. And tension pneumothorax, they're going to have absent breath sounds on the affected side. They may have that tracheal deviation, which is a very late sign, very subtle. And the treatment would be a needle thoracostomy or a chest tube, where the treatment of cardiac tamponade is a pericardiocentesis. So when we talk about distributive, any questions in obstructive shock? Okay. Distributive shock is kind of the opposite. That's excessive vasodilatation and impaired distribution of blood flow. You get a decreased resistance or increased venous capacity from the vasomotor dysfunction. Remember, blood pressure is two things. It's either volume or the size of the tank. And this, you have a tank problem. You have, say, 5 liters of circulating blood, and normally you have a 5-liter tank. Now your tank just dilated out to 8 liters. So now you don't have enough blood going round and round. And examples of that are the neurogenic shock, again, spinal cord injury, anaphylaxis, and septic shock. So neurogenic shock, that definition is a loss of sympathetic tone. It causes massive vasodilatation. That can be from head trauma, but spinal cord injury is usually the most common. But also epidural anesthesia can happen. So if you're involved in a discipline where you're giving epidurals or you're caring for patients, you need to assess for that. Usually very cervical and high thoracic spines are the ones who usually get the neurogenic shock. Signs and symptoms, hypotension, that's the hallmark of all shocks. But this one, you get a bradyarrhythmia and temperature dysregulation. So one of the important things is that we maintain the airway and cervical spine immobilization. We want to prevent further injury. And they get oxygen monitors and IVs. They may be intubated, fluid resuscitation. Medications for vasoconstriction to elevate the blood pressure. Again, norepi. This is where that dopamine's not the one to go to. This is a norepi. That's a perfect, or epi, or direct alpha stimulants, both alpha and beta. But again, it doesn't increase. The effects are more prominent in the vasoconstriction. So increased blood pressure by vasoconstriction elevates the heart rate a little bit. And then for bradycardia, you can give them atropine. So atropine will do that. It's an anticholinergic. And keep them warm. That's a big thing. Keep them warm. Even post, if you're taking care of a patient who has a spinal cord injury, you want to make sure that you don't drop the temperature in the room into the 60s. Maintain the room's ambient temperature warm because they're losing that thermal regulation. Get a blanket for them. Monitor that for the patient. And corticosteroids might be indicated. We spoke about that with spinal cord injuries. That's fallen out of fashion for the high dose, but they still might get some. And then they treat the cause, usually surgery for the spinal injuries and whatever else is going to happen. Okay, neurogenic versus spinal shock. Those are two very different things. Neurogenic shock is a hypotensive blood pressure problem. Spinal shock is just flaccidity of muscles and loss of reflexes following a spinal cord injury that may or may not return. It usually does, but it may not in some cases. But don't get those two confused. Spinal shock is not a shock syndrome. All right, moving on to anaphylactic shock. So definition of this, there's an allergen exposure results in an antibody-mediated reaction. It causes massive vasodilation. Common cause, antibiotics, foods, say peanut allergies, latex, and bee stings. So when we assess these patients, We assess the oxygenation, circulation, and mentation. They usually have these welts, hives, the urticaria, itchiness, angioedema. That's the big one that we want to assess for and intervene with. They may have an altered mental status, hypotension, tachycardia, bronchospasms. These patients are wheezing, they get difficulty breathing. So our interventions kind of revolve around that. Oh my, oxygen monitor and IV. And these patients need epi and Benadryl. So again, we have an allergic reaction. So we want to give that epinephrine to dilate it out, bronchodilators to open up those airways. And these patients, if they have unknown, should have an EpiPen if they can afford it these days. My goodness. And then we need to teach them things. We need to, wear medical identification band, avoid those allergen triggers, and have that EpiPen with them at all times. So that's really important as an educational standpoint for these. But we can intervene, and it's usually subcutaneous epinephrine, unless they're very severe, and then we can give it intravenously. So who has latex allergies? It's those people who are most exposed to latex, healthcare workers, patients who are chronically in the hospital. I would venture to guess there's probably not many hospitals out there that have any latex that we care for day to day. However, there are certain products and certain interventions that are specialized that still have some latex products. So we do need to assess for those latex allergies in those patients. All right, we're going to round it out with septic shock here, endotoxins and other mediators causing massive vasodilatation. Again, there's the underlying key. The most common cause is a gram-negative bacteria. Urosepsis is more frequent in the older clients due to increased use of catheters in long-term care facilities, late detection of urinary tract infections because of decreased sensation, burning, and urgency. They kind of dribble a lot, and it sets them up for those UTIs. And sepsis and septic shock is covered in Module 8. So next week is all on septic shock, sepsis, and MODS. We went over our discussion post today. Is there any questions about this? If not, that's it, guys and gals. Anyone still with me? I put you all to sleep.
We're still here.
I know. My voice is raspy today. I know. I don't know. It's something has been irritating it. So I apologize if it sounded weird today. So any questions on shock? I mean, shock is something that has been touched upon on a lot of your courses. It starts in pathophysiology, and we kind of keep going on and on and on. Yeah, it is cold out, Rochelle, I know. So that's it. I'm going to stop recording.